So Dr. Peabody's right. There are some trials with metformin and prostate. Most of the data was done with ovarian metformin and prostate, and with aspirin and colorectal, and some of that was incidental or actually after the fact when they were looking at the heart data. What it speaks to, the use of those three drugs, what it speaks to is what causes cancer, which we don't really know, but what we know is what does cause cancer is multifactorial. That means there are many different contributors. And we know some of those contributors have to do with how we use fat and sugar. So we've been talking a lot about visceral adiposity or abdominal weight, right? We've been talking a lot about exercise. We've been talking a lot about fiber. In some ways, we're talking around the problem, right? The problem has to do with how we use fat and sugar. And we know that how we use fat and sugar can be a driver behind inflammation in the body. Aspirin lowers inflammation in the body by inhibiting a type of messenger that tells the body whether it's inflamed or not. Metformin changes the way your body uses sugar, and statins change the way that your body uses fats. There are some side effects that are important to note with those drugs. Metformin can have an impact on the liver. Statins can contribute to depression, muscle weakness, and a little bit of fatigue long term. And baby aspirin can result in reflux or ulcers if not taken with food or not taken properly. But I do recommend for patients who are in active surveillance or watchful waiting, if they're appropriate candidates, meaning their metabolic health is not where I need it to be and they're not responding to diet and exercise, David's core values there, which are really important, I do recommend that they go on metformin 500 BID, so 500 milligrams twice a day, a baby aspirin. I don't recommend statins. I don't think the data is strong enough, and I think the side effects are too significant for most of our population. But in conjunction with that, I'm giving them supplements like CoQ10 or curcumin or chromium in high doses, which will help to hit that root cause as well. So I feel like we're asking the question about metformin again, so just as a pat answer, it can be useful for reducing the risk of progression of prostate. However, that data isn't strong enough yet for urology and oncology to be prescribing. However, in a practice like ours, where we're focused on survivorship and lowering risk to progression, we do use metformin in conjunction with other strategies to lower your blood sugar and to get good metabolic control. That means how you use fat and sugar. So it wouldn't just be metformin as a single agent. The idea that you can take a pill and magically lower your risk to progression is kind of the easy way out. I wish it was that easy. So it's not just about metformin. As Dr. Peabody mentioned, your HbA1c, your sugar, is really important. So what your HbA1c is, what your triglycerides are, how you're sleeping, what other kinds of medications and supplements you might be taking, all of that would play into a decision about whether metformin would be right for you.